Well, hello, welcome everybody to our webinar today. My name is Radek Fritsch. I'm a chairman of the pediatric section EANS, and together with me, I have Marna Euler, who's a representative for trauma section as well, but she's also a member of our panel in pediatric section. And I also have Mario Ganau here, who is the chairman of ethical legal committee of the EANS. And, this shows that we have a very complex topic today. It's non-accidental injuries in children, a very controversial topic, different rules, different guidelines in different countries. So our idea was to enlighten this topic perhaps a little bit today from three different perspectives. So we have a specialist in forensic medicine here, Dr. Stray Pedersen. We have a radiologist with special interest for this topic, and we will have a neurosurgeon with us. So first of all, I would like to invite Professor Stray Pedersen from Norway, who is a consultant in forensic medicine and professor at the University of Oslo. He has published extensively on this topic as well, besides other things like sudden infant death syndrome and so on. And here in Scandinavia, he's one of the best experts on non-accidental injuries in children. So Arne, please start this webinar. Thank you.
Thank you, Radek. Let's see if I can open it here. So once again, thank you for inviting me for this webinar. You are it's great to be able to talk to you neurosurgeons, because you are very valuable, and this is such a difficult topic. And it's the only way to work with these patients is to work in collaboration. And I will give you an overview of how we as forensic physicians work on these cases. And as you know, we are not involved before these cases are reported to law enforcement, that is to the police. So just a short disclaimer. A pediatric forensic autopsy is quite extensive, and it involves doing, in addition to the autopsy and dissection, we use always a full skeletal survey and a whole body PMCT. And that's the background, because sometimes infants are found dead at home and they have head injuries. But most of these non-accidental head injuries, they come to the emergency room first. Just short history, Professor Ambroise Tardieu in Paris, he was the first to disclose that infants could have injuries that was not caused by accidental trauma. And he presented 32 infants and children with bruising and with scarring, and he described complex skull fractures. And what he said was blood congestions on the surface of the brain, which we now know as subdural hematomas. His research, it was published, but it was forgotten for about 100 years, until John Caffey and Kempe described the battered child syndrome. And then we know it was later called shaken baby syndrome, and a colleague of yours, Christine Duhaime, had a very important paper in 1998 saying that we cannot disclose that these infants have been injured by shaking alone. Some of them had injuries that certainly pointed towards that they were hit by a blunt impact. And as you know, the CT and MRI scanners were not available before the 1980s, and they have been further developed in the latter 2 decades. So we know a lot more about the injuries inside the head now. Of the terms used, abusive head trauma and non-accidental head injuries, both describing that these injuries are not due to an accident. John Caffey has been misinterpreted in a lot of papers. What he described was not a triad, but a pentade, 5 findings: bilateral subdural hemorrhage, retinal hemorrhages and injuries in the eyes, no signs of impact to the head, metaphyseal fractures to the limbs, and signs of brain damage. And he was a radiologist, and he described without use of CT. So this was in collaboration with neurosurgeons and pathologists. For some reasons, these 3 subdurals, retinals, and brain injuries have been pointed out as a triad, but he described 5 characteristics. And you may be aware that the French neurosurgeon Vincent has been he's published extensively on this topic and had a prospective study of infants with head injuries, and he described some cases where there was a confessed abuse, a confession, and other cases where there were witnessed accidents. And that's this is a fog around these cases because you don't know what to believe. But I use these slides because the injuries we see in abusive injury trauma are not pathognomonic for abuse. You can see subdurals, of course, both in accidents and abusive injuries. Of course, there are ischemic lesions is less common in trauma, more common in abuse, and extensive retinal hemorrhages is more common in abuse. But there is no pathognomonic signs pointing towards shaking or other forms of inflicted trauma. And I will just also shortly go through that there are, of course, a list of other conditions that can mimic some of these injuries. Subdural can be caused by bleeding disorders. Most important to be aware of vitamin K deficiency. But also other more rare diseases, inborn malformations that you are probably quite familiar with, and developmental disturbances is a possibility, but of course, many of these conditions, they have other signs pointing towards these conditions, but these have to be ruled out in a forensic setting. Why is this a hot topic? Well, that is because there is a discussion going on. And in Norway, we've had this it's quite heated debate. Some colleagues that reevaluated cases in the court and said that the medical experts have failed to provide balanced testimonies, that many of those cases that were perpetrators, alleged perpetrators, were convicted. They may have been subject, there may have been false convictions. Retired colleague Knut Wester, she has been very, very high profile in this matter. And this headline says, "The professor who shakes the medical society." And there's been a debate. I've just taken this Norwegian case. We had a response to it. We saw that some of the data they provided was not the complete data, but this is just, you will find in the literature a lot of papers with a different opinion. And what the Acta Pediatrica editor said, it's important to consider research that is challenging and controversial. And this is based, Wester based his discussions on a report from Sweden, where they kind of de-evaluated, degraded the literature on the topic, and saying that the triad cannot be used to point towards that infant has been subject to traumatic shake. There's limited scientific evidence towards that. But that report has also been criticized because the other possible causes of the triad are quite rare findings that is also associated with other findings, as I pointed out. And for example, a large emphasis have been later years about the external enlargement of the subarachnoid spaces, and maybe that can be a risk factor for acute subdural collapse, although it has never, subdural hemorrhage and acute collapse, although it has never been published an acute collapse with this. So just to be, I'll try to be short in 20 minutes here, but I will focus the rest of the talk about what we as a pathologist see in the autopsy room when I examine these infants. And the main findings are the internal findings. Of course, these are children who come to the emergency room without a history of trauma. And they typically come later, so they have already an edematous brain. And over 50% of these infants have severe neurological impairment upon arrival. Some have bruisings, and some, but the subdural hemorrhages and retinal hemorrhages is the most common findings. Bruises are often missed. I only have this image to show you that we often come to examine these children while in the emergency room, just to be sure that we are not missing bruises that is covered by a band-aid or whatever. And of course, if the child dies, we can look in the scalp and we can look at bruises and see that there is in fact subcutaneous hemorrhages. It's just not only blue marks, but it's hematomas. Fractures, my colleague, the radiologist, will probably discuss that, but it's common to find several fractures, rib fractures and limb fractures, and sometimes they can point towards the injury mechanism. And just to show you the difficult case, a 6-month-old girl seeking primary care for swelling on the head, 2 previous episodes with seizures. And the CT shows that she has complex skull fractures, but there is no history of trauma. These are the fractures. The child is neurologically okay, but this is a complex fractures, and so this is reported to the law enforcement, and there's an evaluation going on. There's a small bruise only on the temporal region, and quite commonly in these cases, when being reported, the multidisciplinary investigation disclosed that the history changes. So now the parent says, no, the child fell from a nursing table. We do a reconstruction, and the mother says that she was changing diapers and the child was suddenly on the floor. Okay, so the question for the forensic pathologist is, can this cause the injury? And the answer is difficult. It's traumatic injury, but is it enough with one single impact? Well, it cannot be ruled out. So this is one of those cases that will never go to court, but it's important to treat the patient and by reporting. Skull fractures is difficult. We have the suture lines, and it can be difficult to interpret what is a suture line and what is not. At autopsy, we have the privilege to see whether or not it's a fracture line, but it can be difficult. And we also have the privilege to take the bone samples out and to view the histology, but it can be difficult. The internal intracranial findings. I'll just give you a short overview of important findings in these cases. Subdurals are most commonly caused by trauma. It's been a lot of misunderstanding about this because we've used different terminology to describe these effusions. Inflicted head trauma by shaking, the typical findings is that it's not a mass effect hemorrhage, it's a thin layer around both hemispheres, between the hemispheres, and it's also below the tentorium. So in essence, it's multifocal hemorrhages. It's often of mixed density, and at autopsy or maybe during surgery, you can disclose that there are some injured bridging veins or cortical veins. Mixed density is a typical finding, and the multifocality, as you see here, both above and below the tentorium. At autopsy, we can see the cortical veins like this, and we see that they are, if the child survives a day or two in the emergency room, we often see that these are thrombosed. Of course, this does not say that the thrombosis happened before the subdural. It's rather a reparation effect. Another autopsy image, normal bridging veins, and then the thrombosed vein. And when we open the subdural, this is a fresh hematoma, and it is more, it can mimic a membrane, but this is a fresh subdural. I was just shortly mentioning that we have used different terminology in the past, hygroma, effusions, neomembranes, and chronic subdurals is very, very rare in children and infants. It's more a common finding in older and in adults, but it's still being a term used to describe low density effusions in infants. And the age estimation is very challenging. There's been a lot of discussion about the enlargement of subarachnoid spaces in these cases. And as I will not go deep into this, but it's the measurements you can do is of course invalid if there is a subdural hematoma there. So if it's a subdural hematoma present, you can do these measurements correctly. So modern MRI and AI can be used to make it more easy visual for non-neuroradiologists to see what is a subdural and what is a subarachnoid. Shortly about the retinal hemorrhages. Well, in these abusive cases, retinal hemorrhages cannot be stated as a categorical term. It's not yes or no. They are multiple, they are multi-layered. They are typically extending to the ora serrata, and often you have retinoschisis. That means you have layering, and this is important. You have a pediatric ophthalmologist to do a fundoscopy. We can view them at autopsy, and I always show this image because retinal hemorrhages, they are repaired quite early, especially the intraretinal hemorrhages. So if you examine the eyes on day 3, I'm sorry for the Norwegian text here, you will see that many of the intraretinals have vanished. So it's important that these are described early in the early phase. By intracranial pressure, there can be some bleedings, but they look differently. And at autopsy, of course, we have the privilege that we can extract the eyes, and we see here that there is a typical finding, subdural hemorrhages around the optic nerve. We can see them when we divide the eyes. You see the retinoschisis and the subdural around the optic nerves. We can see them on the microscopy. Lastly, the brain injuries is what is less it's still what this is most less knowledge about how these injuries occur and what is the injury mechanism. What we see neuroradiologically is that we see often that the infants have a very rapid swelling of the brain, often occurring during the first hours after being arrival to the emergency room. And typically, if the baby survives, multicystic encephalopathy can occur. Sometimes we see contusion injuries. We can interpret that, but the most common is that we have the cystics events, and we call it often a cortical laminar necrosis, that the cortex is only like a sheet of paper, and there is a hole inside. In the last 15 years, great work by German colleagues have seen that what we thought was axonal injuries is not very common in these cases. It's a hypoxic ischemic pattern. So we see the shrinkage in the neurons, and we cannot sort out on the tissue itself whether or not this has been caused by a trauma or a ischemic injury mechanism. So we have to look at the whole picture. And sometimes these brains are just damaged, and it's very, very difficult to examine them. And the hypoxic injury is what and the infarctions is what we see. In recent years, there's been more focus also on the medulla. MRI scans should always involve also the neck and the spine. And at autopsy, we see a common finding is that we have the subdurals also around the spine, and also subdurals and epidurals around the nerve roots. And we can see that here, especially on this iron staining, you see the subdurals here. To be short, I've gone through all these slides. Doing a medical investigation in clinical cases of physical abuse, it's a challenging task. We need to review the whole clinical history. We need to discuss the case with the treating physicians, which are often you, the neurosurgeons. Early photos, repeated imaging, CT and MRIs, and ancillary laboratory tests is crucial. Genetic testing. The forensic medical evaluation involves interpretation of the complete clinical picture. And I cannot stress enough that this is, although we often are called upon to do the medical expert work for the courts, this is a joint task. It's important that the medical expert collaborates with the radiologists, pediatricians, and the neurosurgeon and the ophthalmologist. Thank you.
Well, thank you very much, Arne, for a beautiful introduction to the topic. Indeed, before we continue, I just want to remind all those who follow this webinar, there is possibility already today, now, excuse me, to put in your questions into the question and answer box in your Zoom box. And after all 3 lectures, we will go systematically through all the questions and try to answer them. So please go ahead. And then I pass the word to Marianne Euler in order to present the next speaker.
Thank you, Radek, and also thank you, Arne, for an extremely interesting and comprehensive introduction to this webinar. And now it's my pleasure to introduce Dr. Valeria de la Valle, an experienced French pediatric radiologist who will be here for us with us today. Arne, I realized how much information you can get post-mortem, but in fact, we would like to be there before this happens. And that's, I believe, where the pediatric radiologist plays a really important role for us to detect this before any fatal outcome. So please, Valeria, take the word.
Please, your microphone, Valeria.
And could I ask everybody else to mute so that we don't get any echo sounds?
Okay. Okay, now you should see my presentation.
We do.
Okay, so I will talk in the next 15-20 minutes about the imaging findings of abusive trauma in children. So when abusive trauma is suspected, an exact and rapid diagnosis is needed due to the risk of significant morbidity and the potential fatal recurrence. Several medical specialists will work together in a multidisciplinary assessment to detect and confirm abuse in children, with imaging findings being a major part of the set of convergence evidence. In fact, the clinical presentation of abuse can vary and be misleading, but the radiological presentation, including brain and skeletal imaging, offers reliable diagnostic arguments for abuse trauma, even though, of course, there's no specific pathognomonic radiologic finding alone that permits a definitive diagnosis of an abusive injury. So the most common first-line imaging modality is CT, followed by brain MRI, and both should be performed following a strict protocol to ensure good quality examinations. Head CT is performed with a thin section sub-millimeter acquisition without contrast nor sedation from the vertex to the skull base with 3D surface shaded volume rendered reconstruction technique in bone and soft kernel. Brain MRI must include at least T1 sagittal and axial planes, T2 gradient echo, or SWI and diffusion weighted sequences in axial planes with a slice thickness of 4 millimeters maximum. Recent international guidelines also indicate a field radiological skeletal survey in strict technical condition for investigating clinically silent inflicted fractures. Here you can see the ESPR, European Society of Pediatric Radiology guidelines published in last November 2024. And as you can see, investments change depending on the age of the child. A part of the head CT, brain MRI, and skeletal survey, other explorations such as a whole spine MRI or bone scintigraphy are still debated and no full consensus is available at present. And then you have the same imaging recommendation of the SFIP, the French Society of Imaging in Prenatal and Pediatric Imaging. So fractures are the second most common injury in victims of child abuse following skin injury and bruising. Any fracture in a child can be from abusive trauma. However, fracture types that are highly suggestive of child abuse include posterior rib fractures, as shown here, classical metaphyseal lesion, scapula and spinous process, and sternal fractures. Additional findings suggestive of child abuse include multiple fractures involving different skeletal areas and fractures of different ages. Here you have an example of a radiographic skeletal survey in a 1-month-old boy victim of child abuse that shows multiple classic metaphyseal lesion of the knee, so the distal femur and the proximal tibia, and shoulder, proximal humerus. These fractures have a bucket handle appearance on the AP view and a corner fracture appearance on the lateral view. And also you can see multiple rib fractures, some of which are located in the posterior location. So the key neuroimaging findings that raise suspicion for abusive trauma are particular type of subdural hematomas that I will discuss later, sometimes associated with subarachnoid or intraventricular hemorrhage, bridging vein ruptures, often marked with posterior clotting, parenchymal injuries such as cerebral contusion, hypoxic ischemic injury, and laceration, skull fractures with or without swelling of the adjacent soft tissue, and posterior cervical ligamentous lesion. So subdural hematoma is the most characteristic and the most frequent finding of abusive head trauma, and it's seen up to 19% of children with the victim of abuse. An unexplained subdural hematoma is suggestive of abusive head trauma, especially when multiple, when located in the interhemispheric fissure, at the convexity, or in the posterior fossa, including the retrocranial space, as in the example shown here. Subdural hematoma are usually easily detected on head CT, marked with a crescent shape hyperdensity, either homogeneous or mixed, hypodense. You can see here an head CT scan of a 19-month-old boy, and you have right hemispheric and interhemispheric subdural hematomas, more abundant at the vertex, with significant mass effect and subdural hematomas in the posterior fossa. Brain MRI is, of course, more sensitive in detecting very thin subdural hematomas than head CT scan, as in this example shown here. Other less typical patterns that we discussed before, such as hypodense hematoma, can be encountered and need to be confirmed with MRI, which can disclose hemosiderin deposits within the subdural spaces and septation in the subdural collection. And it is important, of course, to use the term subdural collection instead of subdural hematoma if the hematic component is uncertain because of the differential diagnosis that can be discussed. Traumatic rupture of bridging vein in infants is exceptional in routine, and so, of course, the rupture is a key indicator of a violent traumatic causal event. With violent anteroposterior movements of the brain within the cranium that are responsible for tearing. The tear can be partial or complete and will secondarily result in thrombosis at the end of the bridging vein. On brain MRI, normal bridging vein are best seen on standard T2 weighted imaging, as in the example shown here. They appear as a hypointense regular linear structure located close to the vertex and orientated perpendicularly or with different angles at the junction with the sagittal sinus. When ruptured, these veins lose their normal morphology and become irregular and disrupted. Thrombosis of this ruptured vein can be easily identified on MRI susceptibility-weighted images, marked with a hypointense blood clot on the pathway of the bridging vein at the site of the rupture, and extending more or less in the vein, and the so-called tadpole sign or lollipop sign. But also on head CT, ruptured bridging veins can appear as hyperdense tubular vertex clots when imaged at an early stage, as in these two different examples shown here with the lollipop sign and the tadpole sign. And once again, brain MRI is more sensitive in detecting bridging vein rupture than head CT scan. As you can see here, it's the same child. On the left, you have the scan. On the right, you have a particular sequences of brain MRI, and you can see that we don't see clearly a ruptured vein on the scan, but we can definitely confirm the presence of a ruptured vein on MRI. Parenchymal injury. So identifying parenchymal lesions is useful for both the diagnosis and the prognosis. Injuries to the brain parenchyma, such as edema, hypoxic ischemic, or hemorrhage, are very useful in very unusual, in a typical domestic type accident, for example, falling from a low height, without an association description of a significant force. And brain MRI has, once again, higher sensitivity than head CT scan for detecting these injuries, especially during the acute phase. This is an example of hypoxic ischemic injury, which is significantly associated with abusive head trauma in the hypothesis of apnea and respiratory failure secondary to the injury of the craniocervical junction and brainstem respiratory centers. It is commonly found bilaterally and can span the entire neurocortex or be limited just to the watershed areas, depending on the severity of the insult. Once again, it is better detected on MRI diffusion imaging, and they appear hyperdense, as shown here, associated with low ADC, appearing diffusion concentrations. Cerebral edema is one of the hallmark features of abusive head trauma and is causally associated with a significant morbidity and mortality. Even if maximal edema typically occurs approximately 72 hours following the injury, even on an early CT scan performed just 2 or 3 hours of an acute presentation of encephalopathy, the brain parenchyma can demonstrate an amorphous, diffuse, low attenuation appearance with the loss of the normal visible distinction of great white matter. Cerebral edema itself is a non-specific radiologic significant in appearance and has 5 types, with the cytotoxic type being the most frequent type secondary to abusive head trauma. And of course, cerebral edema can coexist with subdural hemorrhage that is frequently of high or mixed attenuation, like in the example shown here, but the volume of the subdural hemorrhage when cerebral edema is present is relatively small and doesn't seem congruous with the parenchymal abnormalities and with the clinical presentation of the child. And parenchymal cleft, last type of parenchymal injury, also described in the literature as parenchymal laceration, are defined as linear cerebrospinal fluid or blood-filled cavities in the subcortical white matters greater than 5 millimeters in size. And they selectively occurs in infants younger than 5 months, where we can see typically contusion in this age group. And the distribution is more common in the frontal lobe. Here you have 3 examples of 3 different children. It's not the same. On the left, you have brain MRI, in the middle brain MRI. On the right, it's a CT scan, but they are 3 different children. And as you can see, the laceration really look the same because they're very, very specific, very typical. And they're mostly seen in the frontal lobe, but they can be also seen in temporal and occipital lobes. And then skull fractures. So regarding skull fractures, CT is better, is superior to MRI to detect the fractures. And they can easily be seen and be detected on HCT thanks to the bone kernel and 3D volume rendering technique. And it's very important to distinguish them from pitfalls, such as a normal accessor suture and normal vascular channels. So we have different examples in 3 different infants. You can see some examples of fractures in case of abusive head trauma in the upper part of this slide, and in the inferior part you can have some of the most frequent suture. Here you have an example of a fracture that we can see in abusive head trauma, but no fracture type is diagnostic for abuse. However, in the case of abusive head trauma, skull fractures are more often wide and complex, such as multiple, bilateral, stellate, diastatic, crossing sutures that can suggest a high energy mechanism and can be therefore suspicious for abusive head trauma instead of accidental head trauma. And here you have examples of ligamentous lesions. They can be analyzed thanks to MRI, not on a CT scan, using a special sequence that I show here, which is a STEER sequence. However, at present, this sequence is not constantly performed in the different radiological centers. Injury to the cervical spine, posterior ligamentous complex seems to be common in abusive head trauma, with the nuchal, atlanto-occipital, and atlanto-axial ligaments being the most affected. And sagittal STEER sequence helps to detect STEER and edema in the spinal ligament in particular. Some condition can mimic the findings of abusive head trauma and must be carefully ruled out to assess the diagnosis of abusive head trauma. So clinical data and laboratory findings are, of course, mandatory. Exhaustive biological tests must always be performed, including blood analysis with ionogram and coagulation factors. And the list of differential diagnoses that must be ruled out will change depending on the number of the lesion presented by the child, only one versus multiple lesion, specificity of these lesions, for example, a simple subdural hematoma versus a specific type of subdural hematoma, and by the number of the organs involved, for example, just brain or brain in association with the skeletal fractures. So in conclusion, some condition can mimic the imaging finding of abusive head trauma and must be carefully ruled out to assess this diagnosis, with accidental injury being the most frequent and the most difficult differential diagnosis to rule out. Some radiological features that I describe are strongly suggestive of abusive head trauma, but the imaging findings described raises suspicions of abusive head trauma, but nevertheless, a multidisciplinary approach remains mandatory. Thank you.
Thank you very much, Dr. De Valle, for an impressive overview of the radiological findings of all parts of the body virtually. Radek, are we inviting questions now, or are we inviting questions at the end?
I would suggest we will do it in the end.
Okay.
Yeah.
In that case, I think it's time to introduce the next speaker.
Okay, let me go ahead. Thank you, Marianne. Next speaker will be Mr. Jay Emoan. He's a senior consultant pediatric neurosurgeon here at Oxford University Hospital and the University of Oxford. I'm very pleased to call him a colleague and a friend. Jay completed fellowship training at the University of Toronto, Sea Kids Hospital, and he has a keen interest in traumatic brain injury in pediatric population, including non-accidental injury. This has led him to serve as expert witness in complex cases that reached court hearing all over the UK. So I'm pretty sure that his experience will be very useful for our entire audience. Without any further ado, Jay, the floor is yours. Thank you so much.
Thank you, and thanks for inviting me. And apologies for being late. I'm going to go through the neurosurgical aspects of unexplained head injuries, and I prefer to call it that because I think it's important that we realize that sometimes we don't know quite what's going on until all the investigations and tests have done. I hope that's up now. Is that showing? Perfect, thanks. So whenever we see a child with an unexplained head injury, these are the things that I try to think about to work out what's going on. And this works for, of course, all of our patients, regardless of their conditions. But in particular, I think when we have babies with unexplained head injuries, there is often a very early decision about what the potential cause is. And we may miss underlying medical or natural causes which may have contributed. So we need to know the history. So it's very important to go back to the basics, as we do as all doctors. So what happened? What's the history? When did it happen? And this becomes important when we're assessing both the imaging and the clinical presentation of the child, and whether it has changed from presentation from when it initially is described. What are the other possibilities that may underline this presentation alongside an unexplained traumatic injury or a non-accidental head injury? And then finally, from the medical legal aspect, in some ways, how do I distinguish the likelihood for these different causes? In the UK, as I'm sure in many countries, there is a record of birth and development of children over time. We call it the Red Book. It is literally a red plastic book that parents get and they carry around to hospital appointments, to the GP. And a variety of important information is written in there. They'll have developmental milestones, and that goes from right the way from the delivery method, gestation, how the babies were, whether they got vitamin K intramuscularly or orally, how they then presented through their developmental milestones, what their head circumferences were, and these are plotted on charts. The family assessments are often very different from healthcare professionals, and these can vary for various different reasons, some of which are social, some of which are just because some people will make mistakes, and that's both healthcare professionals and families. So it's important to think about the fact that a lot of these parents will be able to describe what's happened day in, day out, or week in, week out. And then you'll probably have a stuttering of family assessment from healthcare professionals. And sometimes these may miss changes. We also look, because these can be an indicator of the onset of a natural disease, particularly head circumference versus weight, or unfortunately sometimes repeated abusive episodes. And this will sometimes help if it does turn out that this is a chronic, repetitive, for example, head injury, then it may help to work out when this started to come about, which may then have implications as to who was caring for the child through a particular time period. And I always ask for this red book whenever I'm reviewing a case. If we go through birth, so apologies, I missed most of the last two talks. So Mario, or Radek, if I'm going over stuff which everyone else has done, tell me, because I've got hundreds of slides, so I'll just flick through into something else.
No problem.
Gestation of the child's really important. We always assume that they are born on term, but you have to check, because it makes a difference to what their head circumference is, but also their risk factor for various conditions going on through the development. We need to remember that delivery is a traumatic process, and significant trauma needing medical attention is not as rare as you might think, although life-threatening risks are less than 20% of those are caused by trauma after delivery. Many of those, sadly, will be infection and severe hypoxic ischemic injury. When we think about assisted deliveries, there are various different methods. Obviously, there are forceps, both high and low forceps, with different risks of fracturing and injuries. We've got Ventouse or Kiwi suction caps, and we've got various accoucheur or other methods of digital assistance during delivery, each of which carries an increased risk of trauma to the child's head, with therefore increased risks when they present later on. So depressed skull fractures can be seen with forceps deliveries. Many of you will have seen these in the parietal and temporal region. Remember, the parietal bone is the most commonly affected, both with accidental and non-accidental injuries. Occipital osteodiastasis, it's a normal process to allow the occipital bone to be pushed in during delivery, but in particular, there's an extreme amount of digital manipulation of the head during attempted turning in the vaginal canal or others. You can get some fracturing of the occipital bone that you need to watch out for. Again, look for the history to see what happened during the delivery. Linear skull fractures have variously been described between 1% and 10% of otherwise normal births, mostly through the parietal bone. But remember that we don't x-ray lots of these babies. And so a lot of this data is taken from old studies where you could just willy-nilly irradiate every baby that was born for a couple of weeks and then see whether they had skull fractures. We do know that upper quarter of them are associated with a Keffler hematoma, a subperiosteal hematoma, which is important. But flip it around, that means up to 94% do not have a Keffler hematoma, so it may be completely silent unless you look for them. We're doing some work here in Oxford about birth-related injuries, and I know Ami and others from France have also done a lot of interesting MRI work with delivery. But birth is associated with intravaginal pressures of up to 200 millimeters of mercury during delivery through the cervix. There's a lot of compression, there's traction, and there's torque, which will differ depending on the delivery method, but by no means think that birth is without risk of mechanical injury to the child's head. We do know from studies that I'm going to talk about, the cesarean section, elective cesarean section has got the lowest risk of birth-related deliveries. Forceps, especially in an emergency situation, have got the highest risk. And a big head does have increased risks for a standard vaginal delivery. Important things to understand is that nobody actually knows what the risks of injury at birth are. And we will often see babies who will then present with hypoxic injuries over days after birth, sometimes with an intervening illness. It's important to remember that birth-related injuries may start to become clinically apparent later on. Traumatic injury can present with seizures, with irritability and failure to feed. These are often suspected to be meningitis until a scan is done. Ultrasound scans are actually quite difficult to look at these parenchymal injuries unless they're massive. I'm going to go through the three most commonly cited English language papers about the risks of subdural hemorrhage after birth, but the summary version is up to 2/3 of babies who are asymptomatic with a standard vaginal delivery have got subdural hemorrhaging. I'm going to quickly flick through these because these will be available to read, but the studies by Elspeth Whitby, by Looney, and by Rooks looked at small numbers. So these are in double figures of babies each, and they found a large number of them who were otherwise well had silent subdural hemorrhaging. Why is this important? It's because there are two bits you can think about this. These are thin subdural hemorrhaging, both supra and infratentorially, and that these, in the studies, almost all resolved by a month old. Okay, so it is likely that lots of babies will have a birth-related subdural, but it is likely that almost all of these will disappear through the first month to 2 months of life. Okay, I'll skip this one because it's in the paper, but this is my, in the UK, we call this the back of a fag packet. So on the back of a cigarette packet, once at a meeting, I was writing this stuff down. Not that you should smoke. But if we look at several 100,000 live births in the UK per year, let's go down from the up to 60% of standard vaginal deliveries who may have an asymptomatic delivery. Let's halve that, okay? Then we come down to 230 deliveries will have a silent asymptomatic hemorrhage. Nobody knows what the conversion rate is of asymptomatic fresh subdural hemorrhaging to chronic subdural hemorrhaging. So I've picked a very low conversion rate of 1 in 10,000 does not reabsorb, but stays and become chronic. Remember, these are double figure studies, so there's no way any of the studies we've got currently would ever pick up such a rare ratio of change. So it's not surprising that we haven't noted these yet. But what that means is, by my calculations, there could be up to 23 chronic subdural hemorrhages in the UK that are actually related to acute birth-related subdural hemorrhage remaining and becoming chronic. What's the lesson for me? It is I've now had 2 patients in my 21 years of being a consultant where I have been convinced that this is related to birth. So that means we've done all the investigations and studies and found nothing. For what it's worth, there is really nothing worrying about the histories, and they've been constant and the same from everybody looking after the child. And importantly, when we look at the delivery and afterwards, we do find this change in head circumference that starts to build up just a few weeks after birth. So I am convinced that this can happen, but it's really rare. But not to be missed out, because if you're one of those children and you're then up for an investigation, or one of those parents, we mustn't forget this likely very rare but not impossible rate. Skip this. Symptomatic acute subdurals. I think Dr. Delaval has already been through this, so I'm going to skip through these. This is a baby, an example of a baby who was born 50th centile, one of my 2, and had a head that steadily rose through the centiles and presented with symptoms clearly of raised intracranial pressure, but actually you go through the history and you see that history presenting over a long time. One of the most interesting things about this case was I asked the mum 2 questions. The first of all, what size hats does he wear? And he was wearing hats much older than he should be. And then you asked to look at the T-shirts, and what you'll find is that they were buying T-shirts with poppers on the side and leaving them open, or they were cutting the T-shirt to get it over the kid's head. So it fitted everywhere else, and they were needing to cut the T-shirt because of the macrocrania. These are interesting little tidbits that you get from a history, which are really helpful when you're trying to work this out. And this is us doing a teeny burr hole onto the chronic subdural. We found this membrane and a chronic subdural compression of the cortex, and it was under pressure, which for some reason, I'm not going to play the movie because it's too long, but you can see that, right? It was under pressure. I'm going to skip hypoxic ischemic injury, but it was reviewed. Initially, it was presented by a pathologist from London called Professor Geddes, and she presented now a very controversial collection of 3 papers. Actually, if you get a chance to read these 3 studies, as a neuropathological collection of studies, they are rock solid and fascinating. Where we may disagree, and I disagree with her, is the inferences that are taken from them about the relationship between hypoxia and subdural hemorrhaging. That's always a constant discussion. But if you want to read a really good collection of neuropathological assessments of babies who've died with hypoxic ischemic injury, these are good. Now that we know the incidence of asymptomatic chronic subdural bleeding, it may not be so surprising that there is an association between these two, but what we don't know is what the causative arrow is between hypoxia and subdural hemorrhaging. Okay, I'm going to skip through those. All right, accidental trauma is, what time is it? Oh, crikey, I'm going to, sorry, I'm going to skip through a lot because I've realized I've only got 4 minutes left and I'm halfway through my slides. Ruddick it was, or maybe is, a midwife in the north of England, and a really interesting paper. They looked at 11 babies with shortfalls in hospital. So clearly accidental shortfalls from low-lying cots. And what they found was they got linear skull fractures in some of these babies, but not necessarily with overlying scalp injuries. And a fall of just over 1 meter can cause cerebral contusions and traumatic encephalopathy. Much of these findings, when you go back, are available in the Japanese and the Russian literature, but English-speaking countries, as I don't have to tell many of the audience, are notoriously bad at not looking at any other language. But when you go back, you can find it written back into the 1970s with the Russian papers. But low-level falls can be associated with it. Here's my non-statistician's view. We don't know the incidence of low-level falls, let's say at 1 meter, because that's often the taken distinction between low and medium level falls. We don't know how many babies fall off things at home. We don't know the actual incidence of severe head injuries from the low level falls. We don't know the numerator and we don't know the denominator. We can't calculate the risks of getting a head injury from a low level fall. This is where I'm starting from, is what do we actually know? There's lots of things we can infer. What do we actually know? I'm going to skip through. Mark Dias is a neurosurgeon in CHOP, did a very good collection of studies. John Plunkett is on the other side of the fence, was a very, very clever pathologist who looked at 75,000 playground falls and basically found that a very small number of these kiddies had a head injury related to a low-level fall, some of which were videoed by carers. Summary of this, up until a few years ago, was, can shortfalls cause serious or lethal outcomes? I thought yes. A lot of my colleagues said no. And in 2017 was a study that came out partly from our colleagues from the Netherlands and also from America. And so they looked at 8 witness shortfalls, all of whom had an occipital strike. They were toddlers, didn't fall more than 1 meter, and fell onto hard surfaces. I'm not going to bore you with this paper. You can have a read of it. The Atkinson paper is well worth reading. But here's the thing. These are low falls, standing toddlers on the floor, standing on or sitting on a couch, sitting on a bed. They're falling less than 1 meter. They all presented with symptoms immediately. And if you look at how they present, they cry, they become difficult to console, then they become limp, their eyes roll back and they turn blue. Now, that is exactly like the histories that are often provided after a shaking injury. So this was a very good study to say, actually, an occipital impact can be associated with symptoms very similar to what we ascribe to shaking. And actually, if you go back to this paper, the same paper, but go back to the previous table, you'll see a lot of them had interhemispheric and unihemispheric subdural hemorrhage. So not a lot different from those babies and lots of our shaken babies. Some of them had diffuse changes throughout the brain of a darkness on a CT scan, and some of them had retinal hemorrhages. Christopher Brook provided a paper with this study. I am going to show you this one because I think it's really interesting. Look at this toddler. Falls back. It's very slow, but falls back, and you can see lands on his back, and then his head, occiput, strikes the hard floor. Okay, this was videoed. The video was in a gym creche. So the mother had left the baby in a creche, so it's videoed, and it's obviously in a public spot. There's a 70 centimeter head to ground distance. The mother was called immediately. The baby was drowsy, a bit floppy and unresponsive, and then had an episode of 5 seconds of limb stiffening, back arching and eye deviation. Went into hospital. There were retinal hemorrhages. There was low density fluid and fresh bleeding that then became enlarged over time. Okay, so this is a videoed low-level fall with a very interesting constellation of findings. Bayard found this, presented this baby. The child was found unresponsive and then subsequently died in hospital. There was a right parietal skull fracture and scalp swelling with a small fracture hematoma type collection, a swollen brain, and foci retinal hemorrhages. Classic for, there was no history provided, so this baby was just found like this. Classic history that's often provided after abusive head injury. The mother didn't even think about this at the time because 16 hours previously, she'd fallen with the child and the baby had hit the back of the head, but he'd been fine afterwards. So she hadn't talked about this during any of the histories because she did not realize it was relevant. Now, clearly then you think, well, she's a liar. However, there's CCTV camera outside her house and it shows her foot catching on the drain and it shows her falling, and you can see the back of the kiddie's head hits the ground. Her arms are outstretched, he hits the ground. So these are examples which are just now coming out, especially with, you know, the video world that we live in, where low-level falls or accidental injuries can be confused with a non-accidental injury. I'm going to flick through these non-traumatic causes, but there's lots. Apologies that I've done so much. Do I have time for one more interesting paper?
Of course, go ahead.
Fascinating case. Denton and Milosnich are two pathologists from America who wrote this up in 2003. Baby who was 9 months old, lived with mother and granny. He fell 30 inches off a bed onto a hard floor. So there's a rotational fall and he cried immediately. He was inconsolable in a few minutes. He'd been seen by mother, grandmother, and an independent babysitter over 2 days and very clearly had completely normal behavior. 72 hours after the fall, he's found dead. Just 8 hours beforehand overnight, he'd fed and been given his asthma meds. He did not die of asthma. The post-mortem shows no evidence of scalp injury, but a skull fracture and a thin acute subdural, very swollen brain with a tear in the mid-corpus callosum. No other findings of diffuse external injury. So there is evidence of a delay after an impact to the back of the head again. There's something really bad about the occiput, which led to a delay of completely well behavior and then death. Rasset had a child on a spring who was on one of these in a rocking horse on a large spring, hit his head, continued to play, and then hours later became drowsy and had a big acute subdural and taken to hospital. So I am about to stop now. There is something different about babies. The swelling appears to be more common and often very severe. And I think it is a secondary phenomenon because you do often have these short time periods of the baby being relatively well after an impact, followed by deterioration. I do think it is not necessarily related to the subdural hemorrhage itself, whether it's related to cytokine control, cranial nerve changes, so the talk and die phenomenon that you may have read about or know about, whether these are blood-related mediators, factors we don't know, it's definitely there. I'll finish by saying I do recognize, and I do think that children are shaken. And Catherine Adams-Baum was very clearly able to show these findings of what confession information was given. And you'll see that some of these are clearly people at the end of their tether who are shaking their babies who have subdural hemorrhaging and encephalopathy. They can be heavy, up to 5 kilograms. So these are not necessarily small babies. So I've gone through a lot of the pro-shaking evidence, if you like, because I'm sure that's been discussed by my colleagues already. But I wanted to discuss the fact that we need to be really careful when we are considering these cases. And I'll stop, hopefully, oh, crikey, 6 minutes over, I'm sorry, and say thank you.
Many thanks, Jay, and particularly for the last sentences that were present in your slide, which are certainly heartbreaking. I leave Radek to chair the Q&A session, and
well, yes, let us cooperate on this. Yeah, I know that Mario, you have some questions prepared, but let's start with some questions from the audience.
yes.
The colleague Elizabeth Carson, she's asking. I assume it's a question to you, Jayaratam. It's about ping pong fractures related to instrumented delivery. Have you seen these?
Yes, we have. They're seen both with forceps deliveries, but actually, interestingly, often seen with an accoucheur movement or with an assisted digital delivery. And we will often be called because there's a dent in the child's head, and they get better by themselves.
Okay. Any comments to it? Yeah, Marianne, can you just see the next question from the audience?
Yes. Again, thank you for an excellent overview. And I think it's becoming very obvious that attention to differential diagnosis and differential other causes is quite complicated. So here's the next question, whether there have been instances, or when any of the experts know of instances of penetrating non-accidental head injury, because most of all the reported cases we've seen here have been of blunt trauma or shaking. So anybody knows of penetrating injuries that were inflicted? Yeah, please.
Yeah.
Well, yeah,
Yeah.
I can just answer it from a
Arnie.
basic point of view. Of course, there are penetrating injuries to the head also on infants and young children. These are not so debatable, because it's that's my impression is that it's very difficult, especially for non-physicians, to understand that a small infant or child can have been subject to trauma when there is nothing to see on the outside. So when there's a penetrating injury, that's not so challenging.
Jay, you had also a comment?
Yeah, sadly, I've seen them where children have been thrown and will hit corners of radiators. That's the most common one I've seen. Occasionally larger penetrating ones onto the corner of beds. These are the two. I have not seen, and reviewed now just over 1,000 cases for various procedures. I've not seen anybody taking, for example, a screwdriver or a knife or a hammer, as you might see in our adult population, but I've certainly seen plenty of penetrating against household objects where children are swung or thrown against them. It may be that Arnie's seen more from his pathological basis, but mine have all been against internal things in the house.
I've actually seen an injury inflicted by a sibling who got very furious. That, of course, you can that is also, I would say, accidental, because it happens in shall we say, an emotional surge, but I've seen that, yeah.
It says there are no other questions from the audience. I think Mario, you can go on with your questions.
Yes. So Jay, I would kindly ask you to pass us your experience as an expert witness. What are the legal responsibility of any neurosurgeon who is asked to give an opinion on a clinical history, radiological findings, and clinical examination of a baby and children who might have sustained non-accidental injury?
Yeah, I think it's important to distinguish between those of us who are treating physicians for that child, where we need to give actually a very factual, don't start, saying what you think, and you need to write everything down, a history and an examination like you would for every other patient. So you write exactly what the family say. Really important, because those first early histories are absolutely crucial to know what's going on. For right or wrong, the histories can change over time. And that initial history can be really, really important. So do take your time. Please don't send the most inexperienced member of the team to go down to take that history, because they need to go through exactly what happened. What was the height? How was the child immediately afterwards? All of those things that we've spoken about, or which I've fast gone through, and I'm sure my colleagues have spoken about, are really important when you then come to review it later. And just write everything. Nowadays, there's absolutely no excuse not to be saying, look, I'm going to record this and record that history that's given. Then there's no debate. When you're doing it as an expert witness, the two things I think, you've got to know the literature. You've got to know it back to front. An expert witness should try and avoid saying, on the basis of my 4 cases, it is this, that, and the other. If you haven't seen loads, probably best not to do it. If you have seen loads, still learn from everybody else. Learn from the literature, because these rare events are important. I would say that I would avoid writing a definitive report if you don't have everything, and that's from delivery, antenatal, delivery, development, and acute presentation. You need it all if you're not going to miss something, and you'll miss it if you just look at the in-hospital notes.
Yeah, I think that was a very good answer. The other thing that I would kindly ask you to tell us is, what is the moral responsibility that we as clinicians have toward babies and children? So particularly in terms of safeguarding, but not only that, you have written a very beautiful book, What Makes Us Human. So the question is really what we should do to protect those little patients.
Well, the automatic answer is we want to stop them being physically abused, mentally abused, or even killed. And of course we do. But we mustn't overlook the long-term damage if children are taken from what is a potentially crappy but loving home. And let's be clear about this. There are clear sociological boundaries between both inflicted injury and non-inflicted injury. But however rubbish we might think someone's home life is, if they've got loving parents and have got a loving family, there is an importance resting on us that we do not take a child who's loved by their parents. And in the UK, until very recently, once you're adopted, you did not have any contact with your child. They're gone, they're gone. And even in cases where there's been overturned later on appeals and later evidence, you don't get your child back. So you have a moral obligation not only to look after the physical, but to look after the emotional welfare of those children. And that goes both ways for us. And I think it's really important that we remember that.
Yeah, and this speaks for the complexity of what we do on a daily basis. Radek, please go ahead.
Just a comment. I think what you're pointing out now, Jay, is perhaps first and foremost a task for social pediatricians. because they have all the complexity. I mean, at least in Norway, it's not a neurosurgeon who, creates the whole picture. It's maybe starts to is the question we have now from Elizabeth Garzon again. Who has actually the duty of writing down the clinical history? Is it neurosurgeon in the emergency room, or is it a pediatrician, or shall we engage in social pediatricians, from the first moment when we have a suspicion?
Well, here's my view: is if you have any head injury or any unwell child, if you are called to look after them in whatever guise you're in, you have a duty to make a proper, decent history. Doesn't matter if 2 other people have already done one. That is your job, and you have to do it. And you'll do it from a different angle, eh? You're coming at it differently. You'll ask questions that other people won't ask, and they will ask questions that we don't ask. And then we need to go and speak with our radiology colleagues, look at the scan, have a discussion, and then sometimes you have to go back to the family and go, I noticed this, and then they'll say, oh yeah, some and such happened, 6 months ago or 2 months ago or whatever. The overwhelming number of cases that I see where I think this child should not be in court is because the people at the start have not done it properly.
Mm.
And then you never know. And then you have to say, well, we have to go to court because it's all a bit unclear. And then the child gets fostered for 6 months, or in the UK sometimes 9 months, through a court process. Whereas actually, if you take the history, you'll find the information. I sound like I'm really being anti. I don't know what I'm saying like, but I'm not. It's very easy to make a diagnosis of non-accidental head injury. It's very hard to be sure that when you make that call that you haven't missed something else. And I'm constantly paranoid that I'm going to go to court and say, I think this child has been abused. And then think later, I wonder if that's the case, or potentially as bad or worse, I'm going to say, I don't think this child has been abused. And the child was later killed. I've been involved in 2 cases where I felt it was abuse. The court felt it was not, from various other bits of expert evidence from other colleagues of other specialties, some of which I'll have to say was pretty slack. And those 2 children were killed by their parents at a later stage. So it's not stakes here.
Can I comment to that, Radek?
Yes, of course. Go ahead.
I think it's important to recognize that we or you as treating physicians only have a glimpse of the whole picture at the beginning, in the early phase. And I think it's also important to recognize that we need to that the child protection services and the police have a role in these cases. Now, of course, there might be various bad experiences in various countries, but as a treating physician, one needs to know what are the typical images, what is the typical scenario for an abusive head trauma, a non-accidental head injury. And then if you hear, you say in Norway you have an expression, if you hear hoof stomps, so you hear hoofs and stomps, then it's probably a horse. It can't be a zebra. But in Norway, it's usually a Norwegian horse. So sometimes, and then you have to kind of trust, let these cases, what is the benefit for the child? And I think my Ratnam, you expressed it well, that there is an impact. If you report it, there might be also an impact for the family, but it's a clinical decision there. And then if you report it, then you've at least protected the child, and then we have to trust that the system works, that and if it later on evolves that this is not an abusive episode, then it should be urgent to really quickly write a new evaluation. As a forensic pathologist in Norway, Denmark, Sweden, Germany, the forensic pathologists also are appointed physicians in clinical cases. And I think it's just important to recognize the different roles as a treating physician and as an expert witness. That's totally different role.
Yeah, exactly, because we have a question on this in the question box from John Usua. He's asking, how far we should go in to have some, legal assessment from, or are we just separate experts that only contribute to the whole picture? That should be perhaps run by child protection specialists, as you say, Arne. So it will be probably different from country to country. Another question that we could raise is, of course, can you see any cultural differences? Because we all come from countries where there's a lot of immigration, a lot of language issues. You might have some environments which are quite separated, like some entities that don't communicate so much with the majority society. They may have different attitudes in terms of how they treated children. Do you see any problems with these specificities? Okay.
Yeah, two things. If you're in a country, you obey the laws of the country. You don't obey what you think is right and wrong. So there's that basic tenet. Yeah. However, there are various different methods of looking after children, and in some cultures, children are looked after by siblings, a bit like Marianne was saying, a lot more than in others. In some places, you've got grandparents and uncles and aunties, which is actually known to be very protective. And from our own more Western aspect, I often think about this. So it gets a bit philosophical, but I often think when I'm reviewing the cases and I think about the situation that these people are in, very rarely have I come across cases where I thought this person is truly like an evil person. And mostly when you look through what their life is. So I've had 3 girls, and I can tell you what, I've been pretty damn close with all 3 of them of losing the rag at some point. And anybody who hasn't is probably not really telling the truth, because having babies is hard work. And I'm relatively intelligent. I've got a partner. I've got a 4-bedroom house. So when my babies were really getting on my nerves, I could shut the door and go next door and say to my wife, I need a break. I could feed the child when they were hungry. I could give them medicines when they were unwell. I flick back to if you were a 17-year-old single mother in a single cold flat where you can't afford the heating or you can't afford to feed the child, where you may have had no signposting yourself in your life onto how to look after a child. Quite often, sadly, I think it's not unfair to say a lot of these parents go through a collection of relatively unsuitable relationships. And both these parents and these children are much more susceptible to the natural anger that we all have in us, but which we manage to not use all the time. It's not an excuse, but ultimately what we do is we try and fix kiddies who have been abused. But ultimately, the real thing is about working out why these things happen and try to minimize the abuse happening in the first place, rather than having all these absolutely damaged, head-injured babies with spasticity and pegs and trackies. It's not for us, but ultimately that's how we're going to do it. But there are different cultural aspects to all of the way that children are brought up.
Thank you. Maybe just one little question to Valeria, because I think I can imagine the situation where actually the awareness about this doesn't come from neurosurgeons, maybe from radiologists in some situations. Because neurosurgeons just running through the emergency room many times during the watch, and suddenly you have a kid that you think it's just an accidental injury, and then you know there must be an awake radiologist who actually points out something. How often do you think this is the case in clinical practice, that the radiologist actually is the one who?
Actually, we have two situations. Either is the clinical that has the first suspicion of abuse, and then he sent the child to the imaging to confirm the diagnosis that is suspected. Either they just send us because of the clinical symptoms or for a presumed accidental trauma. And then based on the aspects of very specific imaging findings, we raise suspicion there's something unclear, or the lesion that we see are not, they don't go well with the clinical history reported. And so we have to call them back and to ask more questions. And it's very difficult sometimes for us because maybe we want to be the first person who asks the question, but if we go directly to the patient or to their parents, they're kind of like suspicion, they kind of like starting to wonder why we ask this question. So it's better for us to send them back to our colleague that sent us first, to give him the results of the imaging test that we performed, to ask him our question, and it's him that will see the parents, see the family, and ask more questions. Because most of the times, the family only sees us when we do the examination, and then we give them the results, but we didn't have so much time to talk with them. So they have no confidence in us. They are more confident with our colleagues that they've seen at the unit, emergency unit, for example. So I think it's clever to send them back the family to our colleagues and speak with our colleagues, and then he will pose the question to the family. I don't know if you think the same.
Definitely. I think somehow things have not become easier listening to this webinar, because it's a really complicated situation, and the number of other things to think about is truly a humongous list to encompass. I think you touched the spot, Valerie, by stating that the suspicion cannot be supported on any one factor. It requires both the history, probably repeated history. You have to uncover if there are any inconsistencies there, whether the history is changing too much, and you have to match that to the clinical condition of the child and to the findings. And you have to be very careful that the examinations that you do actually encompass the number of possible or probable differential diagnosis, and that requires you actually to know a lot about, or at least to look up, what are the features of the differential diagnosis that could mimic, because not all of them will be relevant for any one case, but some of them will be relevant for some cases and others will be relevant for other cases. And that needs a very good dialogue with a pediatrician, with a pediatric geneticist, and with radiology, of course. Would you agree with that, Jay?
Yeah, I think you've hit the nail on the head. Know the background. It's not the same as, kid came off the bike and they need to go to ITU and have an ICP monitor. Not that that's simple, but big long-term implications mean we don't do this by ourselves when we look after these children clinically. Of course, we go and speak to our radiologists, we speak to our pediatricians. The same is necessary through a court process. I think there was a question earlier, and I would just reiterate, avoid, especially lawyers or judges, trying to get you to talk about things that you don't know about, because once it's out your mouth, it's pretty hard to get it back in. And then they love roasting doctors. They really do torture us. So stay in your lane and don't be afraid to say, I don't know, you need to ask someone else that.
Takes courage to say that you don't know, but it's important.
Yeah.
I think, Jay, your reply now serves very well as a closing remark for this webinar. We only have this time, but this is a topic that we could, speak about in hours. So I take me the liberty to close the webinar for now, but I hope that we will have the opportunity to continue discussion from another perspectives, maybe in a short time. So thank you all presenters for your time and efforts and for giving us some new insights, I feel. And I will be looking forward to see you at soon occasion again. Thank you all.
Thanks very much.
Thank
Mario.
you.
Bye-bye.
Thank you.
Bye-bye.
Thank you. Bye.